Good evening, and welcome to the January 9th meeting of the Washington Township Healthcare District Board of Directors meeting. I invite you all to stand and join me in the Pledge of Allegiance.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Dee, if you would take the roll, please.
Director Stewart.
Present.
Director Nicholson.
Present.
Director Wallace.
Present.
Director Epen. Director Danielson.
Thank you. We're going to take the agenda a little bit out of order tonight. We're going to move immediately to a consideration of minutes. So I'll be glad to take a motion on that.
Mr. President, I move for approval of the minutes of December 12th, 17th, and 20th, 2018.
We have a motion on that and a second. Dee, if you take the roll.
Director Stewart.
Aye.
Director Nicholson.
Aye.
Director Wallace.
Aye.
Director Danielson. Director Epen.
Thank you. That motion passes. Are there any oral communications this evening? It appears there are none. So we'll move directly to Dr. Choi for the Chief of Staff report.
Good evening. The following are the credential items from for December 11th. The new appointments include Dr. Toshi Haraoka, Emergency Medicine, Dr. Timothy Ortlip of Otolaryngology, and Dr. Nora Pfaff of Pediatrics, with temporary privileges extended to Dr. Pfaff. Reappointments for 2 years include Dr. Sumaira Ahmed, Dr. Stephanie Chang, Dr. Joyce Cho, Dr. Catherine Dow, Dr. Bogdan Eftimi, Dr. Louis Follen, PA William Gade, Dr. Andrew Goldberg, Dr. Lee Guo, Dr. Padmavathi Kudaravali, Dr. Jeffrey Thomas, and Dr. Krishnamurthy Umapathi. Reappointments for 1 year include Dr. Zulfikar Ali and Dr. Ramin Begi. Transfer in staff category from provisional active to active include Dr. Gurpreet Chahal and Dr. Paresh Matmari, and from provisional active to ambulatory is Dr. Pramod Krishnamurthy. Completion of proctorship and advancement in staff category includes Dr. Paresh Matmari of Internal Medicine Hospitalist. And new privilege requests include Dr. Andrew Goldberg, one of the intensivists, and PA William Gade, one of the PA surgical PAs. There are no delete or withdrawal applications or leave of absences, and the resignations include Dr. Marcos Alvarez of Radiology, Dr. Sung Peck, Pediatric, and Dr. Noga Ravid, also Pediatrics.
Thank you. Do we have a motion on that?
Mr. President, I move for approval of the credentialing action items as presented by Dr. Choi.
Second. We have a motion and a second. Dee, if you would take the roll on that.
Director Stewart.
Aye.
Director Nicholson.
Aye.
Director Wallace.
Aye.
Director Epen. Director Danielson.
That motion passes. We're now going to move directly to the action items for this evening. And Mr. Wallace has those action items.
Okay.
Item A.
Yeah, Mr. President, in accordance with district law, policies, and procedures, I move that the board reappoint Ben Saw, MD, Russ Blowers, Miro Garcia, Gloria Villasana-Furness, and Jenny Yee to the Washington Township Hospital Development Corporation for the 2019 calendar year.
Mr. President, I enthusiastically second these reappointments.
Thank you. Thank you for the second. I also would like to say how grateful we are to these people that serve on that group. That's a very, very fine thing they do for the community. So, Dee, if you'd take a roll on that.
Director Stewart.
Aye.
Director Nicholson.
Aye.
Director Wallace.
Aye.
Director Epen. Director Danielson.
That motion passes. We're all happy about that. Thanks. We have Jeannie with us this evening who serves on that board. Item B.
Mr. President, in accordance with the district law, policies, and procedures, I move that the board adopt the finding in the Government Code, Section 54954.2B2, and that the board authorize the Chief Executive Officer to enter into necessary contracts to proceed with the purchase of the mini telemetry system for the birthing center for a total amount not to exceed $67,914.96.
Second.
We have a motion and a second on that. Nancy, would you like to explain that a little bit more for us?
I guess the simple way of putting it is gravity matters. When women are in labor and need or require fetal monitoring, with the equipment we have today, it means they have to go to bed. They can't get up and walk. And that can affect the C-section rate. Gravity does matter, and allowing the mothers to walk with these portable monitors allows them to move during labor, and this could make all the difference in the world. When I found out about these, I felt so strongly that I asked staff to get it ready for your review and potential approval today. There are a lot of moms in the room. I think they understand exactly what we're talking about, and I view this as highly necessary.
Thank you. Thank you. Any other discussion on that item? Dee, if you would take the roll. I'm sorry.
There's a little bit more to tell you.
Oh,
Yes. We are participating in a program with the state of California called PRIME, and funds will be provided to cover the purchase of 6 of the 12 units. We have 6 mini telemetry units now, 2 of which are broken and have to be replaced. The staff feel they need 12 more, and hence the request. There's an immediate need for these units because if they're not available, as I mentioned before, the mothers aren't going to be allowed to walk. And it is tremendously important when they're in labor to do that.
wonderful. Sounds like a bargain. Sounds like a bargain.
I think it's a wonderful thing to do for them.
Good. Ready for a vote now. Dee?
Director Stewart.
Aye.
Director Nicholson.
Aye.
Director Wallace.
Aye.
Director Epen. Director Danielson.
Thank you. That motion passes.
Mr. President, if you could excuse me, I need to attend to important family matters.
You may do that. Thank you for your help tonight.
Thank you.
We'll now return to our regularly scheduled agendas, and we're down now to the Service League report.
No, how about the education?
I'm sorry, I skipped the education session. I should not have done that. I'm sorry.
Yeah, please don't. It's important. This one is.
Just passed my by it. We'd been so through it to so many there.
We're going to
Education
have
session.
2 very capable leaders making this presentation tonight. First is Mary Boron, and she's in charge of our quality department, and Brenda Brennan, who is in charge of emergency services. There's a bill that is now law in the state of California called Senate Bill 1152, and it defines what hospitals must do now when homeless patients show up in the emergency room. I think it was very well intentioned, but poorly structured, I guess is a fair way to put it. Mary's going to tell you what the law requires, and Brenda's going to talk about what it's looked like here at our hospital 1 week into this. Mary?
Okay, good evening. Thank you for giving me the opportunity to discuss the new implementation of Senate Bill 1152. As Mrs. Farber has pointed out, Senate bills can be tricky. You know, the history behind them is typically that events happen and senators are approached and lobbyists meet and try to come up with the best solution for the problem, but then sometimes can have some unintended consequences. And this is a new Senate bill. I'd like to start off by kind of giving you some background on it and how it will be implemented and what the expectations of it are. Jerry Brown was able to sign this into law September 30th of 2018. The law came to the Senate early in 2018 and went through a couple reviews, but was finalized in September. The Senate bill does modify a prior health and safety code that already exists that states that hospitals have to have a current discharge plan in place. So current state is that all acute care hospitals already have policies and procedures that they have to follow on how they discharge their patients. However, this goes a step beyond that. Very specific guidelines on how you manage a homeless patient. This law came about basically because in the last few years, the homeless population, of course, has grown. In 2017, the last homeless count throughout California put the population of homeless patients to 134,278. So obviously quite a few homeless. Specific to our county in Alameda, that's about 5,629. Of those, there are various subgroups, and a subgroup that has particular impact on acute care hospitals are chronically homeless patients. And these are patients who have been defined as homeless for a year, or in the last 3 years have had 4 separate episodes of being homeless. And chronically homeless patients are a group that I mentioned because they tend to have more complex issues around addiction and mental illness and require a lot of resources. So I always think it's important that we focus especially on their needs too. So again, they're 29% of what we're seeing here in Alameda County currently. So when it came to the Senate, it was a result of many cases throughout California where homeless patients had been discharged to shelters with lack of communication to the shelter, not having their medications prior to discharge, not having any connection with community resources that may help them in their overall care, referred to as dumping. And if you read about this bill, you'll hear that this bill alleviates hospital dumping into shelters and is going to mend a fractured discharge process. However, I think we all agree that the management of these patients is incredibly complex, requires a great deal of coordination, and so we'd like to go into the elements of the bill, but then also discuss that, is this really the right allocation, or is this really a shift of that, quote, dumping to just another area that's not really appropriate for homeless patients' long-term planning management. So, getting into it, the stated purpose of the policy is to return this patient back to the community and give them more availability to resources and make sure that they have treatment and shelter and supportive services. Everybody would argue that that is exactly what homeless people need. The question is, how do you get that to them? And this bill is really putting that burden onto the hospitals to plan for. Before we get into that, I think it's important to understand, how do we define a homeless person? And a homeless person is someone who lacks a fixed and regular nighttime residence, obviously, and it could be a person who has a nighttime residence that is supervised publicly or privately by an operated shelter. This could be a person who has to spend time in a public or private place that really isn't designed for habitable human beings to live in, under a bridge, on the street, in a tent encampment, things like that. To give us some common definitions that the Senate bill cites is, if a patient shows up in your ED and they say, I'm living in my car, I have an RV, but I move it from time to time, my family and I are in there, not really stable environment, or I live in a domestic violence shelter, or I've spent my last week in a shelter, I'm staying on my friend's couch. I have a tent and a whole group of my friends who we live behind this bridge on the street, all homeless, of course. And we have to identify those patients when they enter the ED. But some of the details of the bill are that January 1st of this year, we did have to start to comply with some various things, which are, first of all, identifying right away that the patient is homeless, making sure that we are on our way to creating an individual plan for a homeless patient. And we have to do this plan in a way that is culturally competent. It's in the language that the patient can understand. And one of the more challenging aspects of it is that we have got to make sure that we are providing a transfer location where the patient can go to, that the social service area, let's call it a shelter for this example, has accepted the patient. So a patient cannot leave our hospital, whether or not they're admitted or in the ED, until the area that we are transferring the patient to, a shelter in most circumstances, has accepted the patient. And we'll get into a little bit more about why that ends up being such a challenge in the current state of what's available to these patients. Later on in the year, July 1st, they are going to take this a step further, and the discharge plan has to be fully amended to meet all the requirements. It has to be written into policy. All of our staff have to be trained appropriately. We have to have alignment with the community resources in the area, have those documented. Make sure that every social worker, case manager, people working with this population have a list of shelters in their area that they can reach out to see if we can get the patient transferred there. In addition to that, we have to maintain a homeless patient log, which for a lot of reasons I think is good. We want to know who's coming in, what were the issues, what we were able to do for them. So the homeless log will be available after July 1st, although we happen to be actually working on it now to sort of streamline that and understand it better. There's a list of about 9 services that have to be offered to these patients prior to them leaving the hospital, whether or not they're an inpatient or in the ED. Patients have to have a physical exam and be determined for stability for discharge, and they have to have a referral to follow-up care, provide food, clothing, appropriate discharge medications, infectious disease screening, that would include vaccinations being provided, have to allocate and plan for appropriate transportation, and help them enroll into an affordable care program. So of those 9, we'll go through each one, kind of discuss how they define that we do that. Providing a patient a medical screening exam is something that is just common standard practice that across the nation that is done. And we will be and have been doing that before January 1st. So that's, again, pretty standard. Referring these patients to follow-up care is something that's a little bit more concrete in this bill in regards to the fact that we have to provide them with a referred source of follow-up care. You can't just say, follow up with your medical provider and that's that. And we have to be very specific on who it is. And if they don't have it, try to help them plan on getting a primary doctor. And to take it a step further, if they have behavioral health issues, which again, as I described with the chronically homeless patients, 29% of those are chronically homeless in our county, you're going to find behavioral issues a lot in these patients. And there's quite a bit of planning that we're being expected to do prior to that, to connect the patient to an appropriate behavioral health provider, make sure that they're enrolled in the plan prior to going, that the provider care has accepted them, or any appropriate provider that can help them with their behavioral issues. Food is another element that the Senate bill requires. All these patients have to be offered a meal, unless, of course, medically contraindicated. They have to have the meal prior to leaving. If you're admitted, the meal should be provided to the homeless patient within 2 hours of their discharge. If they're in the ED, we do need to provide them food prior to leaving. Clothing, patients should be provided weather-appropriate clothing. And some history behind this bill is that in a lot of the lawsuits that came forward throughout the state of California. There are patients who have been identified sort of at the bus stop. There are pictures, patients have been discharged in gowns, paper clothes, things like this that were obviously inhumane and very inflammatory to see and recognize that humans have been treated like that. And so clothing is a very strict part of this. They have to leave here clothed and in suitable attire. Discharge medications is another tricky part of this Senate bill. The patients have to be provided medications prior to going. If your hospital has an on-site pharmacy that is licensed to dispense outpatient medications, you actually have to dispense and give those medications to them. Our hospital in particular does not have an outpatient pharmacy, as you know. However, that means we still have to provide an appropriate supply, which could be a 3-day supply of their medically necessary medications, which would, you can imagine there's some gray areas in there. And a lot of that will have to do with physician advising on case by case. Regardless, those patients should be leaving with an adequate supply depending on what's going on with their medical condition, or a prescription if they're on the inpatient side, with guidance on how to get that prescription filled. Infectious disease screening is another big part of it, the bill. As you know, these patients are out living homeless, exposed to a lot of different elements, of course, high risk for getting things like TB, influenza. They want them screened prior to discharge, and to see if they meet any of the risk factors for infectious disease and making sure that those are managed appropriately. The step beyond that we have to do is also provide vaccinations. If the patient states, I have not had, my flu shot this year, influenza is a little bit more straightforward, can offer them the influenza vaccine. We do that screening for inpatients now, of course. However, to take it a step further, pneumonia is something that we should be screening for, especially in the elderly. And often these patients are poor historians, are unable to really articulate and remember. I think it's for all of us, it's hard for us to remember when we got a vaccine. And if it's something like pneumonia and you don't know if you've had it in the last 5 years, there becomes a whole nother wave of consideration that an infectious disease doctor has to think about. There could be risks to repeating a pneumonia vaccine, especially the closer together the worse. And so there's some areas in there that make this a little bit more complicated. You don't want to be giving somebody the same vaccine over and over if you didn't recognize that they've had it before. Transportation is another big part of this. The patient cannot leave our facility without having appropriate transfer that we have provided for them within 30 minutes or 30 miles of being in the hospital. And you can imagine that is quite complex in regards to the fact that typically these patients need public transportation. Should we, depending on where the shelter goes, we have to make sure that the BART is set up, or that the bus is, or taxis. They aren't available very much after night. The taxi industry has changed quite a bit recently, and looking at what barriers that brings, and can we get on-demand transportation for them, things like that. Well, I think all hospitals are having to consider right now, but the transportation must be provided and on the checklist prior to the patient leaving. I think that when a homeless patient comes to the ED or is admitted into the hospital, it is a great opportunity to address with them, how can we get you on an affordable health care plan? Are you not registered with Medi-Cal? If you are, we can. What can we do to facilitate you to getting a better payer source while you're here? But again, that's another piece of the financial planning that we have to manage for those patients while they're here. Discharge planning should always be done in a cultural competency manner. We have to take into consideration, are we dealing with language barriers? Are we dealing with cultural issues? And really be sensitive to that and make sure we're not discriminating based on anything to do with any socioeconomic class. We have to be sensitive to that. Make sure that even right down to the discharge teaching that we give them, that it's available at a certain literacy level. So we've always done that, but there are looking at that a little closer now. And that discharge plan should be individual. You cannot do this rubber stamp, homeless patient comes in, check, check, check. No, you have got to show real clear competence to how you managed each one of these elements prior to the patient being discharged. And the discharge post-destination, I think, is probably one of the bigger complex aspects of this. And it states that the hospital must identify a post-discharge destination for the patient. And as I mentioned before, that agency, that homeless shelter, this is the most common, let's say, has to be willing to accept the patient. The second part of that is the patient has to agree to go there. And that may sound simple at first, but a lot of these patients, especially chronically homeless, have a history of being in a couple of these places. They don't like it for whatever reason. They don't like the rules there, or it's too far, or the people that they associate with are not there. There's a lot of refusal on these offers that they're given. And now, if the patient does refuse this, they will stay because they have the right now to refuse that, and we document that, and we move on to whatever else we think would be an appropriate placement. Something to keep in mind with that is that beds are very limited. Of course, you can imagine there's long bed wait times. So if you find a place to put the patient and, you know, it's a celebration, okay, we've got a great place for you tonight, you can go there, it's a warming shelter, it's this, and the answer is no, we've ruled that out now. Now we've got to go a second layer and start looking again, and you can imagine what time consuming and how that stops the flow of the patient through the continuum of care, and how that would impact the flow of patients in the ED who need the appropriate level of ED care. So really complex part of it. Transitional care is another piece that is very clearly outlined in the bill that states that if we are discharging the patient to a social service agencies, which typically are nonprofit agencies, and they've agreed to accept them, we want to make sure that prior to them leaving, they have to have all the written documentation. For for us, typically that's going to be an after visit summary, otherwise known as an AVS. We're trying to get that set up in a manner where the patient can leave with a simply written, easy to understand level of direction about this is where, this is what the course of events that happened to the patient while they were here. These are the medications they're on. This is the plan of care. This is what we agreed upon, so that when they do get to the facility, they can have a better understanding of what happened to the ED. So I do think that serves a great purpose of improving communication, but is another thing that can be somewhat complex with regards to making patients get accepted into a facility. That facility could read this and say, you know, the more I look at this, maybe not a great fit for us here. We see that happen a lot. Or, you know, it's the behavioral health issues were a little bit more complex than we recognized, probably not going to be suitable transfer for here. So again, bottlenecks, barriers, and getting the patient where they need to go. It's very clear that we need to be incredibly careful for how we manage this bill. There are enforcement and penalties associated with it. The California Department of Health can come in and audit and assess and apply administrative penalties of anywhere from $5,000 to $125 per case. There's even misdemeanor prosecution is at risk in the management of these patients. And you know, it says that, you know, the file do not exceed $1,000 by imprisonment or jail, or a period not to exceed 180 days. That's pretty scary language to read. Basically meaning that, you know, if you were negligent or did not follow this precisely, you know, you're looking at fines and even some possible criminal misdemeanors. So that really is the background of the bill and what the requirements are. So the next step comes to how are you going to manage this in our current area? As you know, a big part of our mission is to support the patients of our district and to make sure that we are aware of all resources and that we utilize them and do the best we can to make sure that the patients get all the services that I just mentioned. Those services are important, and nobody is arguing that those services are not important. Those patients need those things. That is very clearly understood here. However, when you live in a county that has limited county resources on the south end compared to the north end, because everybody tends to lump, okay, Alameda County, you hear in the news, oh, Alameda County got, a grant or a bill for, millions of dollars. Oh, that sounds great. Alameda County has got great support for their homeless population. However, you take it one step closer, and you can see in this diagram of the area that when those resources are distributed, a large portion of them go to the North County. We understand and recognize that the North County is in need. 50% of the homeless populations are there. No one's denying that Oakland needs help and needs support. However, that does not mean that South County patients don't. We have got a great burden of South County patients down here who are left with almost no resources, and that's going to be a huge barrier with implementing this Senate bill. There are, as I said, a real lack of shelters, a real lack of behavioral health, long-term supportive behavioral health lacking in the South County. Even something like transitional housing, trying to get patients here into transitional housing that is still temporary, but trying to get them offered into something other than being on the street or being in a hotel. The funds that are associated with that in our South County, including Fremont, of course, is 4%. And that gives you an idea of some of the challenges that we have trying to manage these patients in this area. And as I said, again, we have a responsibility beyond even the community and the hospital, everyone around us, to recognize that this area of the county needs further support in getting these patients and this homeless population the care that they need. And you can imagine the struggle that's going to be when you're trying to manage 5,629 patients and all resources are shifted up in the north and you're limited with the south. So I thought that diagram gives a great picture onto what the patients are going through and what resources we have on getting them there. Currently, to give you an idea on where we are on our plans for implementing this, we obviously have already policies in place for making sure our patients have safe discharge plans. We're going to take that a step further. We're going to amend it to make sure that these homeless patients get exactly what they need in the bill. We are taking it very seriously. We have a multidisciplinary group that meets every week for an hour. And so far, we've been able to come up with a designated area in the ED where these patients have allocated clothing and it's accessible. We have a back supply to make sure that all patients have clothing. Mrs. Farber has made it very clear that that this clothing is to be done in a very respectful manner. Children, we're going to get supply for children. They're not going to be in extra small adult clothes. They're getting specific clothing. We think that's fair and humane. The bill, ironically, did not require things like underwear and socks. When we were in the conference meeting, we thought, we're going to do that. We need to make this a humane process. We've got a full supply of that. Infectious disease, Dr. Martin is fantastic. As you know, you'll be hearing from her later on tonight, actually. And she is really helping us look at how we're going to manage these patients and make sure that they're vaccinated if they need to be and screened accordingly. We have dedicated transport funds that, of course, are not budgeted prior to this because we didn't know this was coming, but we know that we have to provide this. So we're going to have BART, taxi, bus, transportation vendors looking at better ideas for how we can get these patients in the 30 miles or 30 minutes of transportation that they need. Also providing a financial counselor in the ED, that gets us compliant with making sure that these patients are aware of what plans and healthcare plans apply to them and getting them started on that path. Food, as I mentioned, has to be provided. Our Food and Nutrition Services has done a great job of by January 1st, we had lunch sacks available in the ED 24/7 to make sure that these patients have their food prior to leaving. And what we're also doing is really starting to work closer with the local shelters and the housing resources. And This is probably the part of the Senate bill that I find the most difficult, because when you go and you work with these people in the community, they all tell you the same thing. The solution for these people is they need affordable, manageable, supported houses. And that the focus should be on how we can get those resources coordinated to patients in the community. The answer does not appear from anything that I have read or spoken to with the people who live and eat and breathe this every day in our community. It does not live in this patient stays overnight in the ED. It's what can we do to get these patients the sources that they need out into the community. And so, our hope is that as the Senate bill is implemented, we will recognize some of the unintended consequences that probably come from this, full EDs, patients having to stay overnight because they're homeless and they don't have a place to go and we can't get them a bed. And maybe at some stage we'll be able to work closely with shifting that to what they really need, are long-term supportive housing. And it's a hard solution to do, but it seems much more appropriate than taking these patients, shifting their placement in spending the night in the ED with no long-term plan, to be honest. And so we're hoping to see that we can move more in that direction. I think that nothing sort of sends the message home more than hearing stories of patients that come into the ED and listening to what the situations are, because I think when you live it and see it every day, you can understand that really it hits home with what these patients are dealing with and what our facility deals with, and trying to manage them and give them the best care that they deserve. They deserve the dignity, and we're trying to restore that for them. Brenda is actually going to be able to share some stories with you here shortly. As you know, she has a great deal of experience in dealing with this on a day-to-day basis. And I think it helps us figure out what are the next steps that we can do to help offer these patients resources. And that would be Brenda.
Thanks, Mary. Thanks for that really good summary. I know I need something to be taller.
I had to kick it out of the way. So.
There we go. All right, so thank you for the opportunity to share some of the examples of what happens in the emergency department with the homeless. And certainly this homeless bill didn't just bring homeless to the emergency department. They've been coming for a long time. We have some patients that are very frequent visitors. Before the bill, we have a gentleman in his 20s who's been coming to us since he was born. And since 2017, he's been regularly with us. He's an insulin-dependent diabetic. And in 2017, he decided to start showing up with weapons in his backpack. He's had 26 visits in the last year. All but 3 have resulted in admission. He is very sick when he comes. He requires a lot of resources. He's a con man. He has an axe in his bag that he tries to convince us belongs to his grandfather. He has a new grandfather every week, by the way. And he has sharps, he has syringes, and so he puts staff and other people at risk. To top it all off, he's not a nice boy. He's verbally abusive. He threatens people. He was last here on Christmas Eve and spent his entire visit in the emergency department because that was the only safe place to manage him. So the emergency department provided 100% of his care before he was safe to discharge. We have another man who started coming to us. He had about 7 visits in a 2.5-month time frame. He had been a local resident. He had done well. He had been divorced. He was a polysubstance abuser. And his first visit was after 2 weeks after falling off a bike. He had hit his head. Seemed like a simple enough visit. His friend was going to pick him up in the emergency department. We took care of him. He was discharged. 2 days later, he was back. He was brought in by 911. He had multiple complaints. Once again, we worked him up. And we're not talking about an inexpensive workup, right? Because every time they come in altered, they have to have a CAT scan. They need lab values. We have to do due diligence to make sure that they don't have an emergency medical condition. We discharge him home with a friend. A couple of weeks later, he's back by 911. He's found mostly unclothed, laying in the street. He's hypothermic. He's got rhabdomyolysis. He has to be admitted for critical care services. We keep him for a while, and he gets discharged. He's back again days later, and we wind up having to put a comprehensive plan in place for his management and disposition. And every time he came, he became a little bit less nice and would do things that were very unsavory in the emergency department and become verbally abusive and uncooperative, making it difficult to place him anywhere. The continuing care coordinators put a lot of time and energy into finding him a place. He was discharged to that rehab place. 24 hours later, back in the emergency room, and with some representatives from Fremont. During that visit, we were successful in coordinating with a BODE. They got him placed in some temporary housing. 4 days later, he was back with diarrhea, even less nice, and very demanding. And because of all the resources the continuing care coordinators had put into finding his daughters who wanted nothing to do with him and getting him ID and registering him for Social Security, they were able to identify that he had back Social Security funds available, and we were able to get a board and care to take him on faith that he would give them funds when they were available. Now, we haven't seen him again, so our interventions have paid off. Since the implementation of the bill, the word is out. We have had people arrive at the counter, and I'm here for resources. No medical complaint, and if we indicate that we're not the right place for those resources, they suddenly have foot pain, sore throat, chest pain. They're thinking about killing themselves only till 8 o'clock in the morning, right? So once it's light outside, they suddenly become not suicidal at all. Just this week, we had a 49-year-old woman in the ER. She's newly homeless. And, you know, these homeless, they really span a continuum of people that will break your heart, right? That there, but for the grace of God, go I or another family member. You know, I look at some of the homeless, and I can't think of anything harder than walking around with your belongings all day long, looking for a safe place to be, out of the elements. And for those people who just kind of find themselves there for whatever variety of reasons, they hurt your heart, and you feel like this homeless bill is for them. So this 49-year-old lady, she came in, she was newly homeless, had no place to go. We were following our obligations to get her into a warming shelter. She came in late evening after the shelters are full, and we kept her till 3 o'clock the next afternoon before we could arrange transportation to get her where she needed to be. So she spent 15 hours in the emergency room just to be compliant with this new bill, to make sure that she had all the resources that she needed and that she got to where she was supposed to be in a safe way. We had another patient earlier this week who came by ambulance. And we were very busy, but he got into a room. He looked around, he saw the doctor, and he said to the charge nurse, "I can see you're really busy. If it's okay with you, I'm just going to leave. I really just needed a ride to get closer to the BART station." So really abused the 911 system so that he could get an EMS taxi ride just to get closer to BART. Those are just a few of the examples. I mean, we have more examples than that on a daily basis. I mean, we're probably seeing 5 to 9 homeless patients a day that we're aware of. Some people wear homelessness like a stigma. They don't ever tell us exactly what their living situation is because they're still trying to get by and be good citizens. And then there's those that their homelessness is their choice. They're not even welcome at shelters anymore. They've burned all those people out. They're verbally abusive. They're physically abusive. They're aggressive. They're threatening. And so those are the folks that are most challenging to get out of the department because no cab wants to come and get them. They've had them in their cab before, and they're not taking them back. The shelters don't want them, and then they refuse to leave. They're the ones that no solution is good enough for them. So those are just a few of our examples, and we're really happy to have partners like Mary and Kristen and Stephanie and Mrs. Farber to help us at least make sure that we have the resources that we need in the department so that we can meet the requirements of the law in a timely way the best that we can. So, I don't know if anybody has questions for Mary.
Thank you very much to Brenda and Mary. It's very, very sobering information. very, very complex, difficult problems.
I felt the board needed to know what this looks like here. And I think that it was a well-intentioned bill, as I mentioned before. I don't think there was any malice intended here. But basically it was a dump. I don't think anybody knew what to do, and so they dumped it on the hospitals. And it is a very significant unfunded mandate. We'll be tracking the expenses associated with this. And there are really two components. One is finding shelter for people who are homeless for whatever reason, who are cooperative and really want to resolve their problems. The other part is the component of the mentally ill, who don't always act in their own best interests, have a very difficult time following a medication regimen that was designed to help them, and they come back over and over and over again. They need to be in supervised housing where there are caregivers that assure that they're taking their medications. And I don't just mean psych meds, I mean medicine for diabetes, coronary artery disease, or whatever else is a problem for them. And they are not well organized enough in their personal lives to be able to fend for themselves. And they become these very difficult people that nobody wants in their shelter. And what they really need is society's compassion and to be in a supervised setting. We emptied out those institutions during the time of Governor Reagan, and there's been nothing to replace it. And just based on what's going on in the emergency rooms in California, I think there's abundant evidence that those kinds of institutions are necessary for some patients. And leaving them on the streets to fend for themselves, living in the bushes or under overpasses, is an incredible cruelty. They cannot take care of themselves. And that scenario unfolds on a daily basis in this hospital. And we do our best to try and put them in the best possible situation that we can. And a lot of times they aren't willing to cooperate, and they have every right to say no. It is a very difficult situation.
In the process of the presentation, I was hoping that Brenda would say 1 or 2 a week, not 5 or 6 a day. It's really a very,
Since January 1st, we've had 50 or more people present at the front desk in the emergency department and say, I need services.
Wow.
And what they're after is food and clothing.
Yeah.
They don't have medical issues. Not ones anyway that they're going to say they have, unless that's the only way to get to those things.
Thank you. Thanks to both of you. Now we're ready for our service league report. Jeannie, if you can follow that up.
That is heavy and overwhelming and challenging, and I thank you for taking that on and putting it into bite-sized pieces. It just, I mean, anyway, try to pull it together. Happy New Year from the volunteers. We are trying to do our part. I feel like it's just one person at a time, because otherwise it's just too overwhelming. And one person at a time for the volunteers means you're a gift shop volunteer and someone comes in and they're overwhelmed because their family member is very, very ill. And the gift shop volunteer is there to just listen, be someone to understand or to offer a kind word, leave them alone and let them shop, give them a stuffed animal to hold. One person at a time. That's what it's going to take. And I feel like that's what the volunteers are doing. It's just one person at a time. So I'll end with that. Thank you.
Always always good people to talk to.
Yeah.
Thank you for your work.
Yeah.
We'll now have our medical staff report. Dr. Choi again.
So our grand total is up to 592 for membership on the medical staff, 356 active and 100 ambulatory. So that's it.
Thank you. Thank you very much. We keep bumping up against 600.
Yeah, we can't quite seem to stay over that number.
Anyway, thank you. We'll now have our hospital calendar, Nancy.
Okay, we'll start with the video.
Past health promotions and outreach events. During the month of December, Lucy Hernandez, Community Outreach Manager, provided 4 hand hygiene presentations for students at Maloney and Mission San Jose Elementary Schools in Fremont. Information was provided on proper hand washing and hygiene to prevent infection and the spread of germs. 105 students participated. Upcoming health promotions and community outreach events. On Saturday, January 12th, from 10 a.m. to 2 p.m., Lucy Hernandez will provide blood pressure screenings along with health and nutrition information at the Health and Wellness Fair co-hosted by Schilling Elementary School and Mexico Tortilla Factory and Deli in Newark. On Thursday, January 17th, from 7 to 8:30 p.m., as part of the Women Empowering Women series, Dr. Victoria Leapart, gynecologist, will present Fit is the New Skinny. On Tuesday, January 22nd and Thursday, January 24th, from 4 to 6 p.m., Washington Sports Medicine is hosting sports physical clinics for high school students. Student athletes from all sports in the Fremont, Newark, and Union City area are welcome. Each student will receive an assessment and physical to ensure they meet the California Interscholastic Federation requirements in order to play sports. Medical Director Dr. Russell Nord, along with other providers from the Washington Township Medical Foundation, will provide the examinations. Athletes will also receive orthopedic screenings by certified athletic trainers. The events will take place at Newark Memorial High School and Irvington High School in Fremont. The cost is $20. All proceeds will be donated back to the schools for their sports medicine programs. Bay Area Healthier Together. Washington Hospital's partnership with ABC7 continues to provide health-related information and education through on-air programming and on BayAreaHealthierTogether.com. December's featured topic was mental health, featuring Dr. Seema Sehgal. The Washington Hospital Healthcare Foundation report. During December, Washington Hospital Healthcare Foundation received a donation for patients spending the holidays in the hospital. Students in the Leo's Club at James Logan High School provided handmade holiday cards for hospital inpatients. These cards were delivered to patients by the food and nutrition staff on Christmas Day. The foundation will host the 34th annual golf tournament at Castlewood Country Club on Thursday, May 2, 2019. Held in memory of Fremont businessman Jean Angelo Pisano, the tournament promises a day of great golf and fun surprises. To reserve your foursome or to sponsor the event, please call Washington Hospital Healthcare Foundation at 510-818-7350. Washington Hospital Employee Association, WHIA. On Wednesday, December 19th, Janine Zayad, WHIA President, and Carrie Chavez, WHIA Treasurer, visited fire victims in Butte County. They donated goods, including shoes, blankets, personal hygiene items, and gift cards in 2 locations, Paradise High School and the Butte County Sheriff's Office. Representatives at both locations received the donated items with humble gratitude. Janine said, "When tragedy strikes, I am amazed at the kindness of people and so thankful to work for a hospital with such caring individuals." Washington on Wheels WOW Mobile Health Clinic. The Washington on Wheels Mobile Health Clinic WOW is a mobile medical unit providing quality health care services primarily to uninsured and underserved district residents. WOW brings Washington Hospital's commitment to patient-first care to clients throughout the district. During the month of December, WOW served community members at the TCV Food Bank and Thrift Store in Fremont. Ruggieri Senior Center in Union City, and the Salvation Army in Newark. The total number of community members receiving health care from the Washington on Wheels Mobile Health Clinic during the month of December was 10. WOW also provided occupational health services at Materion, a Fremont company specializing in high-performance engineered materials. The total number of community members receiving occupational health services during the month of December was 25. Internet and social media marketing. Washington Hospital's website serves as a central source of information for the communities the district serves and beyond. The hospital's employment section was December's most viewed web page with 31,024 views. The hospital's social media presence is measured through total reach and engagement stats. The total reach statistic represents the number of people who saw a Washington Hospital Facebook post. Social media posts may reach a user via a newsfeed, which is most common, a user's page timeline, or via a direct link to a hospital post. The engagement statistic represents users who liked, commented, shared, or clicked on a Washington Hospital Facebook post. InHealth, Channel 78. During the month of December, Washington Hospital's cable channel 78, InHealth, captured new programming, including a Diabetes Matters program called Latino Food Made Healthy. In addition, InHealth aired 4 health and wellness programs titled Keeping Your Brain Healthy, Taking Charge of Your Health, How to Sleep Your Way to Better Health, and Healthy Happy Holiday Eating. InHealth also aired a caregiver series program called Caring for Someone with Dementia and the December Board of Directors meeting. Awards and recognitions. Marlene McGee was recently presented with the DAISY Award for Extraordinary Nurses. DAISY is an acronym for Disease Attacking the Immune System, and the award was established by the family of J. Patrick Barnes, who died of ITP, an autoimmune disease. His family established the award to honor the excellent work that nurses do every day at the bedside. Marlene began working for Washington Hospital in 2004 as a travel nurse. Marlene's co-workers admire her calm demeanor no matter how hectic the workload may become. As an ED nurse, being tough is sometimes as necessary as being tender. Her positive attitude was demonstrated through the transition to the new Morris Hyman Critical Care Pavilion. Marlene was one of the trainers and reassured others about relocating to a larger space. Marlene is committed to the department and our patients. She emulates what the DAISY Award stands for in addition to patient-first ethics. The Commission on Cancer awarded Washington Hospital a 3-year with commendation accreditation for meeting the 7 commendation level standards. The Commission on Cancer is a program of the American College of Surgeons recognizing cancer care programs for their commitment to providing comprehensive, high-quality, and multidisciplinary patient-centered care. Washington Hospital's Community Cancer Program includes screening and early detection programs, surgical oncology, medical oncology, tumor board, tumor registry, clinical research, oncology nursing, social services, support services, and the Washington Radiation Oncology Center. The American College of Surgeons National Accreditation Program for Breast Centers also awarded Washington Hospital with a 3-year accreditation. Both accreditations were received without any deficiencies, demonstrating Washington Hospital's commitment to quality care based on national standards. The Washington Hospital Healthcare System Pulmonary Rehabilitation Program has been certified by the American Association of Cardiovascular and Pulmonary Rehabilitation, AACVPR. The certification ensures that individual facilities meet the strict standards of practice and are in adherence to the highest standards and guidelines developed and published by the AACVPR. The Pulmonary Rehab Program is dedicated to the mission of reducing morbidity, mortality, and disability from cardiovascular and pulmonary disease through education, prevention, rehabilitation, research, and disease management. For more information on any of the programs mentioned, visit WHHS.com or call 800-963-7070. And please follow us on Facebook, Twitter, Instagram, and YouTube.
Okay, it's my pleasure now to introduce you to the January Employee of the Month, Josh Blair. He's a surgical technologist. He had been working for several years as an EMT, emergency medicine technician, not here. And it provided a solid introduction to what it takes to work in a healthcare environment. And while the work was satisfying, he was not of a mind that the next step of becoming a firefighter was what he was going to do. It wasn't a good fit. A family member worked here as a nurse and suggested that he consider becoming a surgical technologist. And he started the program at Skyline College in San Bruno. His first rotation was at Washington Hospital, and during his second rotation at Stanford, he received a message from the manager of perioperative services, Suzanne Franz, our manager, asking if he might be interested in a position that was opening up at Washington Hospital. Without hesitation, he said yes, and his career with our OR team began at that time. A surgical technologist must have knowledge of procedures, instruments, and how each individual surgeon works. He became part of the orthopedic surgery team, primarily assisting Doctors Dearborn and Saw. According to Suzanne, in addition to the technical skills, Josh has that intangible ability to think 2 steps ahead and act calmly in critical situations. She also notes his professionalism and positive attitude. It's important to find people you can count on. So Suzanne, and Josh is one of those people. Josh notes that the staff who work in perioperative services at Washington Hospital are a unique team. While several departments feel the family-like atmosphere at work, these employees are a small, tight-knit group who must work together to achieve positive patient experiences. When he's not in the operating room, he may be found building computers, gaming, or soaring over the coast with his wife of 3 years, Danielle. He has his pilot's license. And on weekends, he likes to fly to San Luis Obispo for an overnight getaway or to Harris Ranch for lunch. Quite a guy. Very proud to have him here.
It's wonderful to see someone like that progress through the system.
Yes.
It really is. It really is. Good. Thank you. Thank you. We're ready now for our Lean Kaizen report. To hear that from Kimberly Hartz.
Tonight I just want to give a very brief update as to where things stand with our Lean journey. And a couple things, just as we know, over the last 6 months, we have been focusing on, the Lean staff have been really focusing on the transition to the Morris Hyman Critical Care Pavilion. And as you've heard from a number of presentations to the board, they have been really working on looking at the processes and looking at how we can do some sorting and the 5S'ing of different spaces and putting in place processes that will help us in terms of being focused on our patients and effectively moving through the healthcare system. So where we are today is we're about to begin our sort of new value stream. So what we'd like to do is sort of take a break from doing some presentations because for the rest of the next 6 months to a year in 2019, we're going to be implementing 3 new value streams starting in March, April, and May. And we're looking at certain processes and programs that we want to focus on, and they potentially include the cath lab, the lab, patient experience, and revenue cycle, and a few others that we're looking at. So we're going to be starting new value streams and Kaizen workshops related to those. Also, Washington Township Medical Foundation is going to be implementing the 5S throughout all of its clinics. So we're going to do a lot of work really in looking at our inventory and looking at what we have in terms of our supplies. And so we're going to be working on that. And also we're going to be doing some education for the staff who are new and also those who haven't been through some of our classes. So really at this point what we want to say is that we're going to take a couple months of a break in terms of actually presenting to the board of directors as we move forward with some of these new value streams and Kaizen workshops. So that is a brief report.
Thank you, Kimberly. Thank you. We'll now have our quality report, and on antimicrobial stewardship from Dr. Diane Martin.
This time I get the step up, I can see. So thank you very much for letting me talk again on my favorite hot topic here. So a number of things I'm bringing to this description, and including a number of different focus areas that we're working on. So just to upgrade and update you and let you know, there's a mission statement where we try to foster appropriate antibiotic use, education, protocols, guidelines that are accepted by other national groups, and I'll talk about those in a sec. And then also we try to do a lot of interactive discussion between our physicians, and I go to family practice, Department of Medicine, Department of Surgery, as well as some of the other committees to try to get consensus and agreement on guidelines and things that we're trying to move forward. So this is our antibiotic days of therapy. The goal line is 875, and right now we're under it. We're a little bit shorter on our data reporting because we've changed to NSHN, and that requires a little more computer figuring. The Epic is very good in this, but we haven't quite got it running enough to be able to give you the numbers, although we think they look good. So when we break it down, when we're looking at antibiotics that we're looking at in terms of ones used for methicillin-resistant Staph aureus, our numbers have gone up a little bit. Some of the antifungals we've actually improved a little bit. So we're breaking it down by class as well as by total antibiotic use, and as well as cost savings through the pharmacy. And we'll get that probably in a later presentation. Things that we are working on that we're very happy with, the lab implemented a new microscan panel. So on the one hand, this is much more sensitive than our previous ones. So we're actually going to see what we call a breakpoint change. And the breakpoint is where an organism is sensitive or resistant. The breakpoint change is actually going down a little bit. So what happens is things may look a little more resistant than they are. But this is an agreement that has been going on between CLSI, which is Clinical Laboratory Standards and Institute, which is why we'd say CLSI, and also the FDA. There was a lot of disagreement about how they wanted to report those. So they finally were able to reach a consensus, so we're now able to report these more accurately. So we suspected that we had a little more resistance in our hospital environment than we were able to report. So on the one hand, we're getting much more accurate reporting, although it's going to look for the time being maybe a little more resistant. We are projecting a little bit of change, not a dramatic or a huge change. One of them is specifically in terms of reporting urine cultures, because urine cultures can be very simple in terms of a very minor infection versus one that has gone more systemic and involving the kidneys, and we consider those complicated versus uncomplicated. And those are dosed very differently in terms of choices of antibiotics to provide best care for our patients. And with this new microscan, we're able to give those breakpoints between complicated and uncomplicated. So that gives the clinician much more specific information in terms of what they want to pick for appropriate antibiotics. Our antibiogram is done annually, and we're in the process of doing that. Again, data analysis takes a little bit longer than the first 2 weeks of January, unfortunately. We want to also break down by unit, because obviously we are going to see more resistant or more serious infections in our intensive care unit. So we want to do a breakdown by unit if we can, possibly break down by emergency room department, because those are more outpatient versus inpatient. So the EPIC system gives us quite a lot of flexibility, and it was very generous of the board to give us that platform a couple years ago. So we're getting this up and running and giving our doctors much more specific information. The other thing that will probably change a little bit in the antibiogram is because we changed the break point in October, we want to be able to reflect that. So the antibiogram will probably be broken down into two parts. So January through September, and then October, November, December probably will be reported a little bit separately. The next thing that we're working on, again, is the C. diff guidelines. What we were looking through is the Society of Healthcare Epidemiology of America, we call it SHEA. We're updating the guidelines. So they do this periodically, but they did this year with a lot of very specific guidelines. So we wanted to implement those in how our nurses and clinicians look at a patient that potentially has C. diff or we know is transferring from another facility with known infection with C. diff. So right now we're doing a screening bundle, which is how clinicians and nursing staff approach the patient, trying to decide how they want to triage the patient, what the appropriate isolation is, what the appropriate testing is. So that is still a work in progress. The treatment algorithm, because that was fairly specific, it has been approved by the medical staff, and I'll show you what that looks like. So for C. diff, what we want to do is make sure that we're collecting appropriate samples, because what happens sometimes you're concerned the patient might have C. diff but does not have frank diarrhea, and clinically we don't think that testing a form stool is appropriate. We need only the loose or the diarrheal stools. We also want to beef up our hand washing. Our hand washing has improved, but obviously can continue to improve. What we have is what we call secret observers. So we have staff that rotate and do observation. We don't report directly to the person specifically, but mostly to the nurse manager. Or in terms of physicians, it goes to Dr. Brooks. We have a little bit of a challenge in our brand new hospital. The hand washing is way inside the room, so we're having a little more challenge trying to get accurate information, but we're going to work on that. We also want to streamline our antibiotic use. So we are putting information into the system of how to make sure if you're coming up to a patient, you're suspecting sepsis in the ICU, you want broad spectrum. You want all your guns up and running. Once the patient has been under care for 48 to 72 hours, we want to start cutting back so that we're not using antibiotics that we don't really need, or if we need something that's much more specific than what we'd originally picked, we can go forward with that. And I want to continue to compliment environmental services. They have been the workhorse behind this, making sure the rooms are clean. They turn them around as fast as they possibly can. I know the ER is constantly saying, we need a room, and they're working furiously, fabulously to keep the rooms clean, and they do a fabulous job. We still do the ATBS testing. This is where we use a little fiber optic scanner and where we're looking not specifically for a particular bacteria. We're not doing cultures. We're looking to see if there's proteinaceous material, which would indicate the room has not been appropriately cleaned. And so environmental services has their leads checking on this, and they go back and redo the rooms if there's any problems. We target specifically what we call high touch areas. So that would be like the bed rail, the call light, the telephone, the bathroom sink, the bathroom toilet seat, all of those that we consider the tray tables, all of those are high touch. So those specifically are 14 points in a room, and we have guidelines specifically for environmental services, and this is pretty universal from hospital to hospital. So here's our hand hygiene. So the hand hygiene is in green. We're running between 70 to about 80%. Lately a little bit better. But again, we're running a little bit behind our collections because we're trying to negotiate the new hospital in terms of configuration, how to do our observations. So that's a little bit of a work in progress. A PPE is where a patient is in isolation, and we want to make sure that the appropriate isolation is done. A mask if it's aerosol like flu or tuberculosis, gowns if we think it's contact infection like MRSA or C. diff, and always gloves, and more gloves. So we're really pretty good on that part. We just need to beef up our hand washing. So this is the updated treatment algorithm that we went through, and actually there have been a little bit more tweaking that we'll probably do some more because of newer antibiotics that have come out for C. diff. So this breaks it down when you're looking at a patient. Do they have watery diarrhea? Do they have a positive test for C. diff? If they do not have a positive test for C. diff and we don't know what the cause is, like maybe norovirus from one of the nursing homes, we want to continue isolation. So it may not be a C. diff patient and it's in isolation, but an unexplained diarrhea still needs to be in isolation until we figure out what exactly is the potential problem. So for over on your far left side, so an initial episode, we start with the vancomycin, and there are alternatives down in case the physician is not comfortable or thinks that something else needs to be done. We also break it down by first recurrence. In other words, a patient who's been in, gone to a nursing home, maybe coming back, and this is a recurrent infection. And then also by subsequent or recurrent infections, and then what we call fulminant or very complicated. So the guidelines are here. These are ones that are accepted by the societies, the SHE as well as IDSA, in terms of what's best practices. So we put this forward because of our patient first ethic. We want best practices for all of our patients. So the other thing we're trying to do is reach out to the medical staff to make sure that they understand, because not everybody can come to all the meetings. Sometimes you miss a meeting, you might need to step out of a meeting. So we're trying to do an annual newsletter. I'll show you what that looks like in a minute. We're also reporting blood contamination figures to the medical staff in terms of each of the departments, where we have higher rates of contamination in patients that are basically patients on the floor that might have central lines, or patients coming in through the emergency room. We also, as I mentioned, do quarterly updates to multiple committees: Pharmacy and Therapeutics, Clinical Evaluation Committee, the Departments of Family Practice, Medicine, and Surgery. For the staff that's in the hospital, we do an online education called SABA that's updated every year. So we have the newer guidelines also in place in that, and this is something that they do online annually to update themselves. So this is kind of what our newsletter looks like. So we're talking about the improved detection of resistant organisms. We flashed it for look for the asterisk because we want to make sure, and you'll see it's very tiny, tiny little print over there, but it looks better on paper, of the complicated, which is the C UTI, versus the uncomplicated U UTI. So we want to make sure that physicians are going to look for this, so this newsletter will alert them to that, and this will also go out to the staff. We want to send it out electronically, save the paper, and just let them know. The other thing is, one of the antibiotics that's one of our workhorse antibiotics is called cefepime, and that one is what we call a susceptible dose dependent, so SDD. So this is where the lab identifies this as a potentially very resistant organism. Cefepime looks like it might be an appropriate antibiotic, but because of the level of antibiotic needed to kill the antibiotic, we need a stronger, higher dose. So that's called SDD, susceptible dose dependent. So we need a higher dose. And so we want to alert physicians that go ahead and pick the cefepime if you like. It's a good, strong antibiotic, but watch your dosing. And pharmacy will also be looking there right behind us, every unit, looking right behind what we're doing, making sure we're updating, calling physicians, letting them know. Because a lot of times I may make rounds early in the morning. The cultural results come out along about 10 or 11 when I'm back to the office. Pharmacy's right there on the floor, picking up all of the information, picking up, calling you and said, you know, the sensitivity came back. Do you want to look at what you're doing? Do you want to change your antibiotic? We think this would be a good choice. Let's bump the dose up a little bit, and we're in good shape. We also identified by beta-lactamase producers. So this, again, is the different breakpoints. This is the second one that's over here on your left. So that's what the newsletter is going to look like. I'm not forgetting about left and right back. Look like to try to update physicians so they know what they're looking for when they see these new culture reports coming back. The other thing that infection prevention put together is an infection prevention chart. So this is a quickie look for nurses because we have a lot of new nurses, a lot of new physicians. What do I need? Okay, for contact isolation, we need gloves and we need gowns. You need hand hygiene almost always. And then basically hand hygiene going in and coming out, and which specific cleaning product we want. So the purple tops, the orange tops, which one's appropriate. So this is a quick look thing that will be on the units individually. The nurses can look at it. It's also going to be online, but it's basically, okay, what do I want to do? How do I want to handle this? What do I need? They're ready, set, and can go. So here's our C. diff ratio, which is getting quite a bit better. So Ruta and her team have been very, very consistent about making sure when a patient's identified as coming in with diarrhea, she specifically follows up with those nursing staffs and with those physicians and those patients to make sure they're in isolation, testing is done appropriately, and to make sure that if it is a C. diff patient, the patient's on protocol back again with the correct antibiotics. So this is a huge teamwork that's done behind the scenes that we don't always see. And then I'd also like to thank Lena, because she's been my right arm, my left arm person who really helps put all of the antibiotic data together, as well as the numbers, and my PowerPoint specialist. So,
I'd like to stop you for a minute.
Wait.
I want the board to enjoy that chart.
Slide one more.
We're gonna
Okay.
Go back to that. This is totally remarkable by any standard. The hospitals in Northern California were being identified by CDC and Medicare as having an unusually high rate of C. diff. And this is the work of Diane Martin and our staff, and they have done a totally remarkable job. I think it's a standing ovation for you.
Oh, thank you. Well, it's a team. I mean, it's the environmental services team, it's the infection control team. It's not a one-person thing. It's a team.
Thank you.
Thank you. Okay.
Thank you from the bottom of my heart, and thank you for our patience.
Thank you, Nancy. Diane, I was about to congratulate you on that. Mike and I both recognized that slide when it came up. What a wonderful, wonderful accomplishment that is. Really, really. I can't do the math on that, but that's a huge percentage reduction.
Yeah, we're trying to keep it down as low as we possibly can, which is why we're working so hard to educate the physicians, educate the nurses, educate the staff. Like I said, environmental services is doing a fabulous job with all the cleaning that they do. I mean, it's truly a team effort. It's no one person doing this. It's a whole team.
Well, we congratulate you and your team. Thank you. Thank you.
Okay.
We're ready now to move on to our financial operations report from Chris Henry.
Okay, thank you. Tonight we'll be looking at the operational and financial results for Washington Hospital for November 2018. We'll start with our operating indicators. Average daily census continued to be lower than expected at 151.4. We had budgeted 170.7, and again, a lot of that is the impact of the shift in our joint replacement surgeries that we've been talking about from inpatient to outpatient. Admissions for the month likewise came in below budget at 990. We had budgeted 1,093 for November. Patient days for the month came in 579 below budget at 4,542. Our outpatient observation equivalent days came in 18 above budget at 147 for the month. The average length of stay in November was shorter than expected at 4.48. We had budgeted for 4.69 days. Looking at utilization, the case mix index for the month came in higher than expected in the budget at 1.519. We had 120 deliveries in November. That was 30 below the budget. Surgical cases for the month were 18 above budget at 402. That included our joint replacement cases that were 3 below budget at 153. Neurosurgical cases were 7 below budget at 24. Cardiac surgical cases were 5 below budget at 8. So really the big driver on our surgical volume was general surgery. Cath lab procedures for the month were 41 above budget at 343. Our outpatient visits in November came in at 7,123. We had budgeted 7,291. And our emergency room continued to be lower than expected. 4,050 visits in November, about 250 less than what we had expected. Quick look at our cath lab activity. Cardiac and peripheral vascular procedures really about even in the volume mix. Non-vascular procedures, non-vascular interradiology procedures made up 16% of the volume, and interventional radiology, neurointerventional radiology came in at 3% of the volume. Moving to our productivity, productive FTEs for the month came in 36.8 below budget at 1,300.9. We had 143.4 non-productive FTEs, giving us total FTEs for the month that were 61.1 below budget at 1,444.3. Our FTEs per adjusted occupied bed, that's our productivity measure for the month, came in just slightly below budget at 6.68. So again, management did a good job of staffing for the volume. Moving into the financials, as always, we'll look at our Governmental Accounting Standards Board report first. This is the format used for our audited financials. Total patient revenue for the month came in about almost $4.4 million below budget at $169,211,000. Our deductions from revenue for the month came in a bit above budget at 78.15%. Really, our contractual write-offs for our commercial and government-sponsored patients didn't come in too far off of the budget. In fact, a little bit less than the budget as a percentage of revenue. Those contractuals came in at 75.34% of gross revenue against a budget of 75.64%. The real driver here was our provision for bad debt and charity. As we've seen over the past number of months, we've seen that uninsured population growing in the revenue mix. So that number, as a percentage of revenue, came in at 2.81%. We had budgeted for 2%, and the provision for bad debt and charity, as a result, came in almost $1.2 million higher than budget at $4,762,000. So that's really the driver in those write-offs for the month. So we ended up with net operating revenue a little under $1.8 million below budget at $37,422,000. Operating expenses for November came in 4.4% below budget, $1,736,000 at $37,440,000. Really, we were below budget pretty much across the board for our expenses. Salaries and wages were lower with our lower FTEs. Benefits were about $719,000 below budget in the month. That included our health and welfare costs that were $557,000 lower than budget. So our claims were down in November. Our workers' comp claims were actually above budget, about $80,000. And then we had the $225,000 budget favorable budget variance on our post-retirement benefit obligations. That's the credit we're picking up as a result of the favorable actuarial calculation that we talked about a couple of months ago. Couple of items really to talk about this month in the expenses. This was the month when our beautiful new building came online. And as we've been talking about for the past several months, this is also the month where we start depreciating that building and recognizing some additional interest expense related to that construction. So for depreciation, came, right now we're booking it based on our estimate of $3,681,000. That's up about $983,000 from what we were seeing before we brought the building online. Again, depreciation is not a cash impact. It's the recognition of cash flows that have already occurred in the period in which, and the theory here is that you're recognizing the expense in the period in which the building and the related assets are being used up. So these assets are being depreciated over periods anywhere from 5 to 10 years, 15 years on equipment, bricks and mortar over 40 years. So we'll be paying for this in our financials for the next 40 years for this building. absolutely worth it. It's a beautiful building, great for the community and our patients, but we do have to recognize that expense. No cash flow impact from that increase. The other item I want to mention down in non-operating income is interest expense. So this is the expense on our bonds, both revenue and general obligation. Again, there's no cash flow impact. This number increased in the month about $1.5 million. So prior to bringing the building online, we had been seeing interest expense of about $475,000. This month came in at $1,991,000. That cash flow has been occurring for a number of years. This is an accounting convention whereby during the construction of the building, that interest expense gets capitalized as part of the cost of the building. Now that the building's online, that expense comes to the P&L. Does have an impact on our income statement, but no change in cash flow as far as that goes. It's an accounting adjustment. So anyway, we ended up November with an operating loss of about $18,000, just shy of break even, and against a budget of $42,000 net income in the budget. Non-operating income came in about $390,000 better than budget, with a $314,000 loss, and we end up with a total bottom line in November showing a loss of about $332,000. That's $330,000 better than the budget. Quickly, we'll run through our Financial Accounting Standards Board presentation. In this presentation, we actually reclassify the interest on our revenue bonds back up into operating expenses out of the non-operating category, and that results in operating expenses actually $1,795,000 lower than budget at $38,258,000, and an operating loss higher than we saw in GASB of $836,000 as a result of that reclassification. When we come down to non-operating income, we pull out, we actually had an unrealized gain on our investments of a little over $300,000 in the GASB presentation. We pull that out for FASB, and we also pull out the tax income that provides for the service of our general obligation bonds. So we end up with non-operating income from a FASB perspective showing a loss of $135,000, and a net loss from a FASB perspective of $971,000. So, you know, a real impact on our P&L this month of about $2.5 million as a result of that building coming online between depreciation and interest. Again, you know, this is the result of building that building that was necessary for us to comply with the state's unfunded mandate to comply with a lot stricter seismic standards by 2030. So it's a great building. We love having it. We needed it. But really, we're compelled to do it so we can comply by 2030. But there's another way to look at this just to kind of make sense of what's going on in the operation. This is a new presentation that we'll be showing you moving forward. This is EBITDA. And EBITDA stands for earnings before interest, taxes, depreciation, and amortization. And what this does is it gives us kind of a look of what's happening with the cash in the organization. So the adjustments that we make in EBITDA, and again, I'm using as a basis our GASB presentation. We really want to look at what the operation is generating without any non-cash transactions included, and without interest expense. There's no tax impact for us. We are a tax exempt entity. And our amortization is minimal and is included in our depreciation number. So when we pull the depreciation out of our operating expenses, we come to an EBITDA number of $3,663,000 for the month. So the operation really is generating, what that means is the operation's generating about, in the month, $3,600,000+ for the month. That's an EBITDA margin of about 9.8%. It's pretty healthy. Likewise, if you go down to interest expense, we carve out the non-operating income. We carve out interest expense because that's really what we need to fund. So our non-operating activities, excluding that interest expense, generated almost $1.7 million in income. So between the operation and the non-operating activities, we generated a little over $5.3 million to cover that interest expense of $1,991,000 and future capital and operating needs of the district. So the district's still very healthy. It's generating the cash we need to continue operations for the long term. So are there any questions on EBITDA? I know that's a little technical and accounting ease, but we wanted to show you that and we'll give you an idea of the cash flow.
I appreciate that personally. Being a non-accountant, I became familiar with EBITDA about I think it was 10 years ago. Neil Marks sat down and talked to me about EBITDA. And it makes more sense now.
Yeah.
But I personally appreciate the approach.
You know, we really need to look at both what we're doing from a cash basis and from an accrual accounting basis, and it gives you an idea of how healthy we really are.
I'm sure Mike totally understands EBITDA.
Yeah.
Anyway, thank you.
Sure.
Thank you. I think we're ready now for our operations report, Nancy.
We're going to talk about the preliminary results for December. Our gross revenue, excuse me, of $170.9 million for December was below budget by 5.1%, or $9.2 million. The inpatient gross revenue of $120.8 million was below budget by $16.9 million, or a 12.3% negative variance, and $12.8 million below December in the prior year. Outpatient gross revenue of $50.1 million was above budget by $7.7 million. That's an 18.2% positive variance. It's also $8.9 million above December a year ago.
Are joints considered outpatient nowadays?
They're being done, a significant number of them at the outpatient surgery center. But yes, they are.
So that's part of that number.
The joints are being systematically moved out of the inpatient center to the outpatient arena. The shift from inpatient to outpatient is primarily due to joint replacement, changes in reimbursement. One of the things that I wonder about, because they've made this change wholesale, given the age of the people that undergo these kinds of surgeries, this might in fact backfire, and we may begin to see some readmissions. And that may cause the federal government and the insurance carriers to change somewhat their positions on this, because right now they don't really recognize comorbidities. And having been a joint replacement center patient myself, those first 24 hours are critical, and we have physical therapists on the unit round the clock, and they help you build the confidence you need to manage yourself at home so that you do get up and move. If you go home and don't move, you can really get into trouble. And pain management is an issue. There are all kinds of reasons why that first 24 hours in-house are crucial, and I'm very concerned about what the insurance carriers and the government are making patients do. I don't think it's sound medicine. Okay, the major drivers of revenue variance. We had surgical services cases below budget by 39 in number, or a 10.5% negative variance. Therefore, our surgical services revenue is coming in about $310,000 below budget. The inpatient days were below budget by 635, and that drove our room and board revenue down by $2 million. The lower level of inpatient activity drove ancillary services revenue below budget by $7.1 million. You can begin to see how that weaves its way through the house. In terms of our key census statistics, the average length of stay of 4.93 was just slightly above budget, 4.91. The average length of stay was longer than December a year ago. Outpatient observation days were 44 above the budget. They were 49 more than a year ago. Our average daily census of 158.6 was below the budget that called for 179.1. In terms of our admission trends, we had 167 below the budget of 963. That's a 14.8% negative variance. Major drivers of the admission variance are the shift of joint replacements, again, to the outpatient setting, and they reduced admissions by 46. Our deliveries were below budget by 10. The reduction in deliveries seems to be something that's being experienced throughout the industry. The birth rate has dropped nationally by 3%. Neurosurgical admissions were below budget by 12. General surgeries were below budget by 29. In terms of our patient days, we had 4,917, below budget by 935, again, largely because of joints. Surgical trends. In December, 331 cases below budget by 39. Inpatient surgeries were 92, below budget at 197. Outpatient surgeries were 53 above budget, and those are the joints. The increase in outpatient surgeries are the joints shifting from inpatient to outpatient. In terms of surgical activity, our cardiac surgical procedures came in above budget this month by 3. Joint replacement surgeries were below budget by 9. Neurosurgical procedures were below budget by 12. General surgical procedures were below budget by 21. Cath lab procedures for December were 308 in number, and they came in 16 below the budget. Inpatient cath lab procedures were above budget by 1. Outpatient cath lab procedures were below budget by 17. In terms of cath lab activity, the peripheral vascular procedures were above budget by 7. Neurointerventional radiology procedures were below budget by 1. Non-vascular interventional radiology procedures were below budget by 3. And cardiac procedures were below budget by 19. The deliveries, as I mentioned, are below budget. They're below budget by 10. We had 143 deliveries. Non-emergency outpatient visits of 6,561 were below budget by 391, or a 5.6% negative variance. These are OB checks coming in below budget by 102, respiratory therapy visits below budget by 104, lab visits below budget by 160, x-ray visits below budget by 108, and infusion visits above budget by 74. In our emergency department, we saw 4,350 visits. They were 442 visits below budget. In terms of productivity indicators, our productive FTEs were below budget by 100.6. Non-productive FTEs were below budget by 4.1. Total FTEs of 1,490.6 were below budget by 104.7. Total productive FTEs per adjusted occupied bed of 5.48 came in below budget. Budget was 5.68. Total FTEs per adjusted occupied bed of 6.64 were below the budget of 6.81. So along with the reduction in activity is control of the FTEs in response to fewer patients. Other operational statistics include the outpatient surgery center, which had 501 cases in December. They were 16 above their budget. Clinic visits of 3,199 were below budget by 524 for the month of December. Washington Urgent Care came in below budget by 273. The Nakamura Clinic below budget by 163. The Newark Clinic, which has a new doctor on site, was above budget by 46 visits. Warm Springs Clinic down by 140, and the Ohlone Clinic had 6 more visits than had been budgeted. Preliminary information on our payer mix for the month of December is favorable. Government-sponsored patients' revenue made up 68.1% of total gross revenue. I haven't seen it that low in a long time. Our budget had called for 71.9. HMO revenue was 3.8% of gross revenue, which is above the budget of 2.9%. PPO revenue was 25.8% of gross revenue, which was above the budget of 22.9%. Private pay revenue was consistent with the budget, and it came in at 2.3% of gross revenue. Days cash on hand for December ended at 164 days, down 27 days from the last month. We had major cash disbursements in December, which included the annual pension and the OPEB contributions. Days of gross revenue and accounts receivable were 54. There were $158,508 in charity care applications pending or approved in December.
We have already considered our action items for the evening. We'll now adjourn to a closed session. We're going to reconvene to an open session, announce that there was no reportable action taken during our closed session, and there being no further business this evening, with this meeting is adjourned. Thank you.